Thank you all. And thank you, Sarah, for the introduction. I want to thank everyone for taking the time out of their day, as we were just talking about, to attend this. I know everyone's really busy, and webinars and Zoom meetings have become kind of habit. So I appreciate everyone being here. Today we're going to talk about the continuum of care. And so I think this is a topic that actually I truly enjoy and am passionate about educating people on. And it's one that's not talked about a lot because there's not a lot of like data or scientific evidence necessarily standardized within the industry. So we're going to cover, what do we mean when we talk about the continuum of care? What the continuum of care from a residential program level to a PHP or IOP looks like, including individual therapy and recovery coaching, the continuum of care in a PHP and IOP setting, and then also mapping a successful and effective continuum of care plan. So first and foremost, in order to talk about continuum of care, we need to know what it is. So SAMHSA defines it pretty simply by saying it's a treatment system in which clients enter treatment at a level appropriate to their needs and then step up to more intense treatment or down to less intense treatment as needed. And so if you look at ASAM, the American Society of Addiction Medicine, they are the ones that kind of define continuum of care and what the levels are. And they define it on a pretty linear process. If you look at their visual, I prefer this visual because to me, continuum of care is not necessarily linear. As the definition states, people can kind of come and go into more intense, less intense as appropriate. And so there's different stages surrounding the continuum depending on where a client is in their stages of change. So stages of change is very important when reflecting on continuum of care and how it relates to the client's experience in treatment. So, as I said before, ASAM has really clearly defined levels of care in the continuum. And so there's 5 main levels. Some have subsets. Level 0.5 is, I don't know why they didn't start at level 1. It doesn't make any sense to me. But level 0.5 is early intervention services. Level 1 is outpatient services, so individual therapy, as well as opioid treatment programs and maybe group therapy. Level 2 is subdivided into 2 subsets. 2.1 is intensive outpatient, which generally goes for about a minimum of 9 hours a week. And then 2.5 is partial hospitalization, which is generally a minimum of 20 hours per week. Level 3 is your residential inpatient services, and that has 4 subcategories. 3.1 is a clinically managed low intensity residential. It's equatable to like a sober house with probably some clinical care involved in, whether within the sober house itself or another facility. A 3.3 is a clinically managed population specific high intensity program. 3.5 is a clinically managed high intensity residential program. And 3.7 is a medically monitored intensive inpatient. So 3.5 and 3.7 are generally what we talk about when we talk about residential levels of care. There's, variety of distinctions between the two, but they're pretty minor in comparison to the main distinction between 3.5 and 3.7 is that 3.7 has 24-hour nursing, which is why it's a medically monitored intensive inpatient. And level 4 is a medically managed intensive inpatient service. So that's more of like a licensed hospital. It may not be a hospital itself, but like a psych hospital or that kind of setting. So sorry, real quick on the last slide, I forgot to mention recovery coaching you're going to see is actually not on the levels of care because it's not considered a clinical level of care. However, I want to stress the importance that recovery coaching is incorporated throughout all of these levels of care. And so while they're not deemed a clinical level of care, they help facilitate getting clients to the appropriate level of care in the continuum and also then making the right next steps as well. Thanks, Meredith. So now that we know there's 5 levels of care with some subsets, of course, ASAM then defines 6 dimensions for how to determine where people should go within the continuum. So the first dimension they're going to look at is acute intoxication and or withdrawal potential. And so this means, does someone need detox? Do they need an inpatient detox? Do they need ambulatory detox? Or do they not need detox at all? Dimension 2 are biomedical conditions and complications such as high blood pressure, diabetes, a seizure disorder. Dimension 3 is emotional, behavioral, or cognitive conditions and complications. So mostly referred here in the substance abuse industry with co-occurring disorders. meaning anxiety, depression, PTSD, all the above. Dimension 4 is readiness to change. So I mentioned that earlier. For stages of change, it's important to know kind of like, are they in pre-contemplative, contemplative, preparation? Where are they in that kind of stages of change circle, so that we know kind of how to grade them on their readiness to change. Dimension 5 covers relapse potential, continued use, or problems. And then dimension 6 covers recovery and living environment. And the way ASAM does this is they have a crosswalk that we're going to show you a sample in a second, but they have a really nice crosswalk, and it's used, people score it. There's no set way of scoring it that ASAM has come out with that I'm aware of. I know different facilities use different scoring measures. What I see most frequently is either a score of 0 to 3 or 0 to 4. I prefer a 0 to 4 score. So 0 being no risk, 1 being mild, 2 being moderate, 3 being high, and 4 being severe. And so when we look at the crosswalk, you'll understand a little bit how the scoring pattern is used. So here is a very condensed version of the ASAM crosswalk. Feel free, you can Google ASAM crosswalk and probably get the full picture, or you can go purchase their book and it will be in there. But if you look on the left-hand side, you'll see the levels of care. The top is the dimensions. And so these are just a few of the levels. There's many, many more levels, but these are the criteria. I know it's hard to read, it's pretty small. But this is the criteria when you're looking at, is someone appropriate for this level of care? You know, what are they scoring in these boxes? So if you look at like level, if someone is scoring dimension 1, a 0 that's stable, they basically are not going to meet for a 3-7 level of care. So you can kind of get rid of that. So level 2-5, if you go up to level 2-5, could they have withdrawal potential and you just don't know it yet? So you want to monitor them daily, but they don't need to be in a medically monitored area. Or do they have no potential at all? And so that could be, if it's a 0, then it's a level 1 or level 2. And so it's really a useful tool to kind of, if you're unsure of what level of care they need to be in, to kind of go through and score it. And you'll see, if you want to go online and look kind of dimensions, if dimensions, 1 and 2 are 0, then you're going to need a lower level of care than if they're a lot higher, because dimension 2 is also medical issues, medical complications. So Mountainside Residential is certified at a 3.7 level of care. So it doesn't mean all of our clients meet for that high of a level of care. Some fit for 3.5, some fit even for 3.1 by the end of their stay. And the idea is that by the end of a client's stay, their acuity goes down, and so their scores on the ASAM crosswalk also go down. Go ahead, Meredith, thanks. So we talked about, now we saw the ASAM crosswalk. How do you use it? So a little vignette that we have is Kat is a 32-year-old female who admitted into inpatient treatment to address her alcohol and benzo use disorder. This is Kat's first treatment experience, and she reports being able to drink recreationally up until about a year ago. Kat has 2 young children whom she's the primary caregiver for. She reports a trauma history stemming from childhood and presents as open to exploring trauma treatment modalities. She reports her husband is supportive of her recovery, however, he works long hours. She shared her mom is willing to watch her children while she is engaged in clinical programming upon discharge. So I went through and did my version of the scoring for the ASAM dimensions. So for dimension 1, she's not in withdrawal potential. She's been through at least 30 days of treatment, alcohol and benzos. She probably had some detox before that as well. And so she really counts as a no risk for withdrawal potential. So that would be a 0. Dimension 2, there's no mention of any physical aspects or physical issues within her recovery or medical condition. So that would be a 0 as well. Dimension 3, I marked as mild or moderate. This is co-occurring disorders for cognitive, emotional, and psychological because of her trauma. Dimension 4 is her readiness to change. This is very subjective, as a lot of things are in our field. And so I perceived her as being highly motivated to continue her treatment since she did just complete a residential program. And so I marked her as a low risk for that she is pretty highly motivated and ready to change. Dimension 5, would be, what is the potential for relapse? So I mark this as a high because I find it hard to market anything lower when someone is leaving a 30-day or a 24/7 care facility. It's hard to say it's going to be lower when they're going back to their same environment. We don't know what it's going to look like. They might feel prepared. They might have all the tools they need, but when you put them back in the same reality, it could be a high risk for relapse. And then dimension 6 I had for recovery environment is moderate. She sounds like, it looks like she has a supportive family. However, her husband's not home and she has 2 young children. And especially if it's during COVID, 2 young children at home while starting a path on recovery can be fairly challenging. And so I marked that as a moderate. And so her recommendation for level of care would be level 2, intensive outpatient. Now, the ASAM Crosswalk is used, I don't know if anyone's had the experience of using it, but our utilization review team will tell you quite frequently that insurance companies, when they're fighting for clients to be authorized or usually for longer lengths of stay in residential or pre-certed for a different level of care, if they're disagreeing on what level of care a client should be in, I hear the UR team tell me all the time, they ask us to pull out the ASAM crosswalk and they say we'll go through it together. And just because they're going through it together doesn't mean they have the same perception of a client's risk in their recovery environment. So now that we just went through the ASAM crosswalk and kind of what continuum of care is, how to place a client appropriately, how do you actually do it? It's very easy to go through boxes and score them and say, perfect, this person's gonna fit, needs residential. Then you have to go tell the client or the identified person and say, this is your level of care that we're recommending. I know not many people take their recommendation 100% of the time. And so client willingness plays a huge, huge part in proper level of care placement. As ASAM only has 6 dimensions and only one of them is readiness to change, I think that client willingness covers probably about 75% of clients getting into the right level of care. And so clients' motivation, engaging that, and usually motivational interviewing to understand where a client is really important, because if you put them in the level of care that they're not ready for whatever reason, they could leave, they could, kind of forego their treatment experience altogether. And so their motivation is really important, whether that's internal or external. So family support, and again, whether that's family of origin or chosen family, recovery coaches are really helpful in this, reference, legal even. Like I said, external motivation is still just as good as internal. And then the top 3, as you can see, one of the top 3 points I talk about is insurance utilization review. If a client is self-pay and has unlimited funds, they can go wherever and wherever is appropriate, which is fantastic. However, most of the clients that I've worked with are utilizing insurance of some kind to pay for their treatment. And so what I've seen most kind of disheartening and where clients kind of fall apart a little bit, or where the treatment process falls apart, is when you get a client who may have been on the fence, but now is willing and ready to go, and then insurance doesn't cover, or insurance is terminated because they lost their job and they didn't know. And so it's important when you're trying to get clients into the appropriate level of care, if you're working with the facility or a referent, they should be able to give you an idea when you give them like a vignette of what the client picture looks like, what their insurance is, or their like affordability and resources. They should have an understanding and be able to tell you, this is what we think we're going to get for coverage. It's not foolproof, but any reputable facility or private practitioner, recovery coach should be able to assist you in that. So then once they're in, if they ever get to residential, once they're in there, we talk about aftercare and residential. And Amanda is going to say the same thing that I'm about to say in her part of the presentation. But if anyone's worked for or had to go through state licensing, accredited by CAR for Joint Commission, aftercare planning begins the first day a client enters treatment. And actually in our organization, we ask our clients on their phone screening, what are your plans after and whatever service they're looking for? A lot of them say, my goal is just to get there. I'll figure that out later. Some have full 6-month plans. Some families have full 6-month plans that the clients are not aware of. but it definitely begins the day they walk into the door, primarily because you don't know how long you're going to have them. And so to continually reassess throughout their treatment and to have that conversation ongoing is really important, and not to let it wait because a client, for whatever reason, emergency might happen, funds get cut off, whatever it is, you don't know how long they're going to be in your care, and you want to make sure that it's being talked about and constantly reassessed. So you're going to constantly reassess client motivation, clinical needs, resources, and what are the constraints if they have any. Like, do they have to, for legal, go to a halfway house? Do they have to go back to work as their FMLA or short-term disability only lasts 6 weeks? So all those need to be taken into consideration and consistently reassessed. So appropriate aftercare for residential, ideally someone goes in the order of the continuum. So if they need detox, they go to detox, then they go to residential, then PHP, IOP, individual therapy, and throughout that whole time they can have a recovery coach. If clients don't want to go to PHP or IOP because for whatever reason, it could be too time consuming because they've already taken so much time off work, or they're just kind of unmotivated, you can kind of build some clinical hours around with individual therapy and recovery coaching that will support PHP and IOP level of care, but without the same restrictions or like time constraints. And so we never really want to discharge someone from a 24/7 monitored facility to nothing. And so something's always better than nothing. And the more hours we can get at the beginning with our eyes and ears on them, then the better it's going to be for reassessment and understanding how they're doing. And then you titrate down accordingly. So aftercare and residential. So who's involved? So now that we know what level of care to place people in, how, what's expected, what's appropriate, and after they're in residential, who do we include? Everyone, basically, is the answer. As many people as possible. And that's allowed, that the client allows you to. So the client, primary clinician, family, referent, legal, and again, the recovery coach. We have a lot of clients who come in with a recovery coach already, attached to them. And so this is great. The recovery coach helps us with leverage. The referent helps us with leverage, to get them to maybe be more motivated for the appropriate level of care. When I first started at Mountainside, we had it was about 12 years ago, we had one continuing care person for about 60 clients. We now have 6 continuing care people in the department, and they're case managers, and they work with our 12 clinicians, so they pair off. So each case manager has 2 clinicians, and they work with them. And how we do the clinical referrals is we have our clients and clinicians complete an assessment together based on, what are obviously the client, what do they expect, but also what are their resources, do they have a family? Do they have to go back to work? Do they, what are the constraints? What is the best care based on their previous treatment history? And so they'll complete this assessment together, and then the clinician will make a referral. And we've actually been able to use the ASAM Crosswalk to help kind of show our clients, like I said, an evidence-based model that's like, it's not just us saying you need extended care, or it's not just us saying you need IOP. This is actually where you fit based on your scores and these criteria. So it's a good tool to help leverage and let clients and families understand where the referral is coming from. So once the clinician makes the clinical referral, we have a case conference, and that's with the continuing care case manager, the client, the family, the clinician, anyone else who's involved that wants to be, so everyone's on the same page. And so this prevents kind of staff splitting or family splitting, saying, I talked to the case manager, they said this, that's not the referral my clinician made. So we find getting everyone on the same page in terms of aftercare recommendations is really important from the get-go. And so from there, the clinician is solely responsible for just increasing the motivation to go to the next appropriate level of care. And the continuing care case manager meets with the client to review, okay, based on the referral, here are some options that we've already vetted that we think are approved, where you can go, like the dorm. And here are the resources. And then the case manager is the one dealing with the family on finances. So we kind of split the clinical and the case management so we don't interfere with that relationship. But it's really important just to remember that aftercare in general starts on day one, whether you're in residential or, as Amanda's about to talk about, in PHP or IOP.
Thanks, Alex, so much. So yeah, I'm going to talk about the continuum of care and the importance of thinking about aftercare even at the outpatient, PHP, or IOP level. And I'm going to repeat again because this is so important. It really is. I remember not only with things like CARF and OMH, but I remember just one of probably within the first 2 weeks of school and getting my master's degree in social work that we learned about this. And it was such a foreign concept then. Like, you're talking about how to help clients to leave a program before they're even really started a program. But aftercare and discharge planning really do start from day one. And in some ways that's really empowering for a client because it allows them to know that they're working towards a goal, especially working with adolescents or young adults. 90% of clients are not walking in the door excited to be in treatment. They're walking in the door angry because their parents or their families have, forced them here, and they want to know what they need to do to get out of here. And I think we really also need to start where they're at and run alongside them and set up sort of concrete goals and objectives that can help them to see the light at the end of the tunnel. And then the other thing, of course, that's such an important concept is that assessment is an ongoing process. You don't do an assessment the first 48 hours of treatment and then sort of, wash your hands and say, okay, now let's just move forward. We're constantly assessing and reassessing a client as they grow and change in the treatment process, and also as the environment around them changes as well. Um, you know, I think that when people are in residential treatment and when families go to residential treatment, they go in somewhat accepting of the fact that there will be an aftercare plan. They might be resistant to the intensity level that the aftercare plan probably clinically needs to be, but many people are pretty well educated that, you go to residential and then, there needs to be some type of, well, what's next? That just, you don't just complete residential and then you're done with treatment. I think there's a little bit more resistance, especially from family members, about this idea of aftercare planning being crucial even at the PHP or IOP level. And that's where a lot of coaching with parents is crucial, because we want to stop this revolving door where clients are constantly going in and out of residential treatment to aftercare, to residential treatment to aftercare. And we can stop that if we get aftercare right. And part of doing aftercare right is having aftercare for aftercare. There needs to be a step down after the step down. And that's how you present the rehospitalizations and the continuous need to go back to residential, which in and of itself can create a trauma for the client. So what are some of the goals of aftercare planning in an outpatient setting? There's a handful of goals. First, obviously, we always want to make sure that we're stabilizing whatever is going on clinically. When clients come to outpatient programming following a residential stay, I think it's so important to educate them and their families that it is normal for there to be some sliding back into some old symptoms and some old behaviors. You are leaving one place and transitioning into a new place, and transitions are hard, transitions are uncomfortable, and with transitions, you might see a little bit of a flare up in symptoms, and that's okay. You're getting used to a new environment. So as we're transitioning and entering into this new phase of treatment, it's really important that we're continuing to stabilize symptoms and also watch how symptoms evolve, because being away from the natural environment is safe, and re-entering the environment presents the individual with a lot of new triggers. And What's nice is that when strong aftercare is in place, there's the opportunity to practice using skills in the face of those triggers in a supportive environment. You're not left just totally on your own. The next thing that we really want to do in outpatient treatment is we want to do some skills-based learning. And by skills, this looks different for different clients because they come to us with different areas of strengths and different deficits. For some clients, that might be really working on social and emotional skills. For others, it might be executive function skills or DBT skills or social skills. But the point is that when you are in an outpatient level of care, it's not just about stabilizing clinically, it's about how to help prepare clients to experience success in the outside world. And that requires skills. For instance, if somebody has major deficits in executive function skills, but they want to go back to school, sending them back to school without teaching them the skills to be successful in school, like how to organize a planner, how to schedule your time effectively so that you're not procrastinating and pulling all-nighters to finish papers. That is the job of outpatient programming. And this is the place where clients can practice doing these skills as they are partaking in life events in the real world. What we also want to do at the outpatient level in preparation for aftercare is we really want to help clients to solidify a social support network and a connection to the community. Treatment isn't forever, and treatment shouldn't be forever, at least not at an intensive level. But we want to replace the safety that the treatment community provides a client and the scaffolding that treatment community provides a client with things in the external environment. So, for example, if this is a client with a primary substance use diagnosis, getting connected to 12-step meetings, getting connected to sober networks and fun sober activities is a great way to utilize outpatient programming in anticipation of successful aftercare. It's, I think, actually more tricky and challenging with clients who don't have a substance use diagnosis because there's not just the AA meeting to go to at night. So how do we help connect a client, let's say with a primary diagnosis of bipolar disorder, to community support so that when they are phasing down an outpatient treatment, that they're able to find the supports that they need outside of treatment. And that might be finding local community groups, support networks that are free and that they're there and they're available to the client. It might be, that clients want to volunteer with young children who are diagnosed with mental illness. It could be a variety of things, but connection to the community is key. Next is family work. When clients leave residential treatment and enter into outpatient treatment, the dynamics in the family system can shift. And as much as many of our parents and families love seeing their kids improve and stabilize in residential treatment, when they come back home, the natural tendency can be to fall into old patterns and to unwittingly create the perfect storms for symptoms to reemerge. So whether a client is 16, 25, 40, or 60 years old, involving the family in outpatient care is critical to effective aftercare planning. The family is a part, if let's assume that the family is a part of their network, is a part of their support network, then that family needs to be involved in the plan. And then finally, we really want to talk about building a life that's fulfilling and that's fun and that makes people feel good about themselves, whether that's school, whether that's working or volunteering or internships. It's really helping a client to sit back and say to themselves, who am I? And what do I like to do? What do I want to do with my life? because they're no longer in residential treatment. They have access to the outside world. But for many of our clients, they've been stuck in their illnesses for so long that they don't even know what they like. And part of outpatient treatment is experimenting and trying different things and taking risks. And that enables clients to really identify, not only who they are, but what things in life make them happy and make them feel like they have a sense of purpose and a sense of meaning. So how do we get there? Because that's a lot of goals. And I think that, both clients and their families who have spent time in residential treatment, while they accept that, aftercare is part of the plan, I think where there's some resistance with how long aftercare generally tends to need to take. And clients tend to want to get there super fast. Like the day that they start outpatient treatment, they want to start working a full-time job, or they want to go back to school full-time. And, for us, it's about really helping a client to understand that we don't want you to just get a job. We want you to be able to maintain that job. And if we do things too fast, sometimes we end up, cutting off our nose to spite our face. So sometimes moving slow and steady is the way to go. And we believe that aftercare planning at the outpatient level, it means that we need to have a very phased treatment approach, where in the beginning, things are going to be a little bit more intense. And maybe more time is going to be spent in the treatment facility than outside the treatment facility. But a month, 2 months in, that shifts. And maybe 50% of your time is spent working in school, and 50% of your time is spent in the treatment center, doing your group therapy, doing your individual therapy, continuing to practice your skills. We tend to like to hold steady at that 50-50 level for at least 3 or 4 months, just to enable clients to sort of ride that wave and really gain solid footing. And then we start talking about, okay, what does more maintenance level treatment look like, where you're working full time or you're in school full time, but you're still just continuing maybe a couple hours a week of maintenance level treatment, whether that's therapy or coaching or 1 or 2 groups a week, just to maintain the gains that you made. And then here's the kicker. You can do that forever. I mean, you can really do that long term. There is nothing wrong with seeing a therapist or a coach once or twice a week ongoing. And that is the aftercare to the aftercare plan. What do I need to do long term to continue to feel good about myself and to continue to maintain the gains that I've made? The the process of self-discovery and self-awareness and self-love, it is a journey. It is not like this final destination that you just get to, because life always throws curveballs. And just when you feel like you have something under control and you're, working your dream full-time job, or you've gotten into your most like sought after school and you're participating in these clubs and you're loving life, something might happen. And it's nice to always have that sort of solid home base that that you continue to utilize as support. And there is nothing wrong with that. You're not going to therapy ongoing because you need to. You're going because you want to, because you value the process, because you value the journey that you're on, and that it's working. And I think that's when we know that we've done, our jobs, is when clients now want to continue in the process and see the value of it, versus seeing themselves as being sort of forced into it. I think the other thing that's really important too is, treatment really needs to be integrated and holistic, especially in primary treatment and residential as well, but more so even in aftercare, because again, you're in your natural environment. You're exposed to many different triggers, people, places, and things. And it's not a one size fits all model. While, conventional therapy might work for some people, or conventional DBT programming might work for others, some really respond well to things like mindfulness, meditation, yoga, exercise. We need to have a toolbox that is filled with a diverse set of tools. So at any given time, we can handle life on life's terms, because that is what outpatient treatment is about. You are in real life and needing to handle life on life's terms. We also need to blend conventional therapeutic care with the clinical coaching. And that's what I was talking about with more of the concrete skills-based work. Okay, you want to go back to school, but do you have the skills to do so? You want to get a job, but do you know how to do a job interview? Do you know how to write a cover letter? These are concrete skills that you'll use now and then take with you for the rest of your lives. And then finally, the family work, as we spoke about before. And I think that this is also key in terms of the aftercare to the aftercare, is that family work is also an ongoing process and you don't just graduate from doing family work. The family system is a very interesting system, and the tendency is always going to be to go back to that original homeostasis. Even though it wasn't a productive or healthy homeostasis, it was comfortable and it was what they knew, and it's what they've been doing for years and years and years. So you always have to be challenging family members not to fall back into those old roles or patterns that will lead to an old homeostasis that's really built around problematic symptoms for the identified client. So, before we end, I just want to briefly talk about this, because, I don't, so much research has been done on what makes treatment effective. And a couple of things that we know is that length of stay is undoubtedly correlated with positive treatment outcomes. The longer that you stay in treatment, the more you're going to get out of treatment, and therefore outcomes are going to be better. So when we look at length of stay and retention, we're always trying to maximize those. The other thing that we know is that, studies have shown that holistic treatment and a community integration treatment approach also is correlated with positive treatment outcomes. This is just general research, but what we really wanted to look at least at the dorm, in terms of the outpatient model that we provide, which is very phased and is really like a longer term aftercare model, is, well, what does that mean? Is what we're doing here consistent with what sort of general research is saying? And if so, what kind of outcomes are we seeing? So we did launch an initial, at least, research study, and we're in the preliminary stages of findings because we've been collecting data for about 9 months. So we do need a little bit longer to get more robust data, but the preliminary findings are actually are actually pretty fascinating. We're looking at things like generalized anxiety and depression, and then we're looking at quality of life factors. We're looking at friendship, rejection, ability to participate in life, and self-efficacy, because those are the things that, when those scales are moving in the right direction, clients are experiencing satisfaction and meaning in life. And initial results are showing that generalized anxiety has gone at intake from moderate to mild. Depression started either at more severe or moderate levels, is now down to mild. There is an inverse correlation between friendship and rejection levels, which we expected. When people feel less rejected by the world around them, they are also at the same time tending to report more satisfaction and higher scores on their friendship assessments. We're seeing a clinically significant increase in the ability to participate. And this is huge, because this is what we want. We want to help young people to participate in life outside of treatment in a way that's meaningful, productive, and sustainable. Sustainable is so key there. And what we're seeing is that the ability to participate in self-efficacy scores are approaching neurotypical levels at the 9-month mark. So, what we really want to do now is just continue to collect data. And then obviously post-discharge data is going to be key, because it's not only getting clients to a place where at the 9-month mark or at the 1-year mark that they're showing these clinically significant levels of improvement in different areas, but post-discharge that they're actually maintaining that. And, I think that having this continuum of care where at the residential level, the professionals are involved, are really prepping the family for what is to come in the outpatient level. And then once they get to the outpatient level, that we're prepping them to understand that, yes, we know that you loved residential treatment, that you're so grateful for them. And we all don't want to see you back there again. We want to see you succeed. And in order for that to happen, we really need to have a very systematic and phased approach to outpatient care, because there is more aftercare after aftercare. So looking ahead, we're just going to, again, be looking at what can we do, and how can the continuum of care process continue to be improved? How can residential and outpatient providers be collaborating and coordinating with each other during those critical times as you're approaching discharge at the residential level, to help prep families and clients for what is to come? And then just, looking at future research, obviously, for all of these different areas. And with that, I am going to turn things back over to Sarah, although I do see John here too, but I think Sarah's doing Q&A, to take us through a Q&A, because I'd love to hear from all of you, and I know Alex would as well.
Thank you both. That was really, really interesting. And I just appreciate all the, reminders about how important it is to really, truly assess people for the appropriate level of care and understand where to start. And then the very beginning of the conversation also includes, how are we going to end this process? Welcome to where you need to be now. And let's also do some kind of future forecasting about this process needs to continue for a really, really long time for those outcomes, like Amanda was talking about. I've said to lots of clients in the past that I think recovery takes 4 seasons, to be able to think about what does it feel like in the spring, summer, winter, fall and winter, and all the triggers that come up around those things, but also just seasons in kind of a more global term about like all the things, all the things that pop up in life. So, you're welcome to put questions in chat, and I see that there's one that popped in. So as we get started with some of these questions, if there are other questions that come up, please just put them in the chat and we'll make sure to get to as many as we can. But one question that came in while you all were talking was, Elizabeth asked, how has the pandemic been impacting aftercare planning? And here we are a year, everybody's talking about a year, and it's our pandemic anniversary. So thinking about meeting support networks, finding jobs, all that stuff that you all were talking about. So Alex, do you want to speak a little bit to that, and then maybe Amanda can chime in too?
I'd love to. Thanks. So I saw this question come in, and when we first saw the pandemic unfold, I think it impacted a lot more at that time. Now as we're at our anniversary, this is just the norm. This is the way it is. So it's not as impactful anymore because people are used to it. But at the beginning, we had clients who were in residential treatment who found out their jobs, they were laid off while they're in treatment. And so then it's like, how do you even talk about aftercare? Because they're now worried about their livelihood and supporting their family. We had clients who truly just up and left because they're like, we have to go provide. And it's hard, to tell them, no, stay longer for your recovery when you can't support your family. How we have adapted, though, to the pandemic, at least from our outpatient and residential locations, is we realized we had to use our own internal resources a lot more because we didn't have the fellowships to refer to. We didn't know who was in person, who was not in person, and things consistently changed, or constantly changed and consistently, I guess. But we created actually a whole new alumni ambassador program. So we had it, we kind of revamped it, used the people that we know that are doing well as basically like a new sponsor, because it's hard to go meet a sponsor. We increased our free virtual offerings. So we had meetings every day because people didn't know where they could attend meetings. So a lot of free virtual offerings in our ambassador program. And then also the use of recovery coaches, I saw skyrocket during the pandemic, because they were people who were seeing clients. They could go outside with clients, meet them truly where they were at physically and emotionally, and in a socially distanced way. But recovery coaches, I felt, were a huge piece of the success of clients and during the pandemic.
Thank you for that. Anything you want to add, Amanda?
Yeah, I think that, obviously the pandemic, it challenged us all as mental health providers to think outside of the box and to be creative, as it did the whole world, because the reality is that human connection, social connection is vital to mental health and mental wellness. And what we saw is, I think generally speaking, people were sticking around in residential programs a little bit longer just because it was safe. And what am I leaving? What am I coming back to?
Yeah, we did have that. We had the flip side of that as well. Yeah, you're right, Amanda.
And then by the time that they got to us, the thing is that the world did adapt, and I think our clients in some ways adapted easier to a virtual world than we as adults did, just because they're used to doing things virtually more than we are. And there are opportunities to volunteer virtually. When New York City was on full lockdown, there was so many people in need and lots of opportunities to do service. 12-step meetings were still alive and going strong. They were just on virtual platforms. You could still go to museums and do tours. It was just, it looked different. And for a period of time, we had to get creative, and we had to sort of figure out ways to connect in a virtual world. As the world opens up more, and has been opening up more over the course of the past 8 months or so, it has certainly gotten easier. But this has no doubt been a challenging time. And I think mental health statistics are demonstrative of just how challenging these times have been for individuals with pre-existing mental health conditions, and for people with no history of mental illness as well.
Folks are also welcome to turn on their microphone and just chime in if you feel more comfortable saying anything that's coming to your mind, or if you have a question.
I have a question.
Oh, go ahead. Yeah.
Hey, it's Lloyd. I was actually almost done typing, and I figured I might as well hop in. So, I feel like everybody here, wishes, right, that families and their loved ones would just say, okay, if this is what I need to do for my loved one to give them the best shot at staying well, then that's what we'll do, right? We'll send them to the intensive residential. We'll have them do the continuum of care. They'll go to the dorm for 9 months after, continue with a therapist and a psychiatrist, whatever that looks like. But we all also know that that's a lot. It's very hard to get them in that place, right? They all want the one and done, cure and that kind of thing. And I was just hoping that Amanda or Alex, you might be able to share just some tips for the people here on sort of how you've been able to warmly, get folks to sort of open up to that. And the other thing to, in addition to that is, I wonder if, I'm wondering if there is a specific place that you guys see where it's like, where you're open to compromise, right? So like, let's say somebody's at the dorm for PHP and like, you think that they should be stepping down to IOP and doing, you know, a continued 12 hours of group work a week, and they are ready to get that job and you don't really think they are. At what point, if they are willing to do some work, do you sort of say, okay, we know that you could benefit from 12, but we'll agree to 3? Or whatever it is. And I know those might not be, you know, I don't know if you'll have specific answers for those, but I just sort of thought you could elaborate a little bit more on that kind of stuff.
Did you start, Alex?
I'll start. You can jump in after, Amanda. So, Lloyd, I feel like you're asking me when you do normally about your admissions that you might, or referrals you might have. Can we bend down our program length of stay?
And the answer I get is only if clinically appropriate.
and I know, yeah. So we do, I mean, to be honest, I kind of forgot your first part of your question, but the last part of your question I remember is we assess everyone individually. Yes. Is there a treatment model we would love for people to follow? Of course. Doing the full continuum, staying longer in treatment, whether it's residential, PHP, IOP, and just consistency, even in the same program or the appropriate program, is great. However, that is like a rare case and few and far between. We get someone who's like, I've totally given up. You will do whatever you say, or they logistically can't, you know, for work or for family. And so there, we truly build a model around that person. And we have clients all the time who say, I don't agree with your clinical recommendation for aftercare, you know? And so to me, it's the clinician's job as a trained therapist to enhance their motivation to do that aftercare recommendation. But if they don't, it's not like we're done with them. It's not, back in the day when I first started, it was like, fine, you're on your own, find your own ride out of here. You're not following a recommendation. But now we know, you know, it's not as cut and dry. And so just because someone, you know, doesn't want to do 24 sessions of IOP right when they get out, okay, can we do 15? Sure, you can do as many as you want. I'm not going to charge you for the unused sessions. However, once you're there, we're going to encourage you to stay longer if it's needed. So that's one piece. And then I think that kind of correlates back to, actually, I remember the first part of your question being like motivating families and clients. And I think a lot of it comes down to making it appealing financially. 100% I see is like the biggest reason why families don't want to pay for things, or they've paid for things so many times. What's going to be different? And so I'm a big fan of CBT. And so I use or like pros and cons lists, like what's your thought process here? So what's going to be done differently? Let's analyze that. So kind of like decision tree it out. What are your options? And when you kind of if you're working with rational people, it works. When it's not so rational, it gets a little tricky.
Yeah. No, just to piggyback on that too, Alex, I agree with everything that you said. And I think that, you know, sometimes the intervention is allowing them to do the less intensive form and not take clinical advice, so that they can experience the natural consequences of that. And as they do, you're still there because you're involved. So they're not going to fall, you know, so hard, and you're there to help, you know, pick them back up, because natural consequences, especially with young people, can provide wonderful clinical opportunities for learning and growth. Now, obviously, you don't want to put a client in a clinically dangerous situation. That's a completely, you know, different, a different course of action would be taken there. But if it's cuspy and you kind of know that 15 hours is not ideal, they really need 25, but there's so much pushback. Okay, let's do the 15 and let's see how it works. If it works, awesome. If it doesn't, and we see that, let's you and I agree right now that you will understand that we will be, you know, moving up in terms of intensity, and just allowing them to have that real life experience of the natural consequences. And then in terms of parents, you know, it's funny because you can use all the analogies that you want, and sometimes people still just don't want to hear or accept the reality of how dire the situation is. It's much easier in some ways, you know, being a a medical doctor where you can put an x-ray on a screen and say, this is your tumor.
Mhm.
And this is the exact amount of chemo and the frequency that you're going to need to save your life and to shrink this tumor. We can't put that x-ray on the wall. We know what amount of treatment is going to be sufficient, but quantifying that and explaining it in a way that's digestible without that like visible picture is not always something that the family wants to hear. And again, sometimes it's the family that needs to experience the natural consequences of making a decision that goes against medical advice.
And Amanda, I like what you said was about, okay, we're going to do the 15 hours, but if it doesn't work, we're moving to 25. And so I think having that kind of agreement in advance and just the transparency up front is very important, and it doesn't always work. It doesn't, some people are like, we're not doing it, bye, and that's their choice. But I've actually found that I find families, parents or spouses, negotiating treatment with me more so than clients. And so I've had to negotiate terms with a loved one who then is the one who violates the terms. And so unfortunately though, they're attached to that client. And so you kind of have to work with that. But yeah, I think setting the terms in advance, if people want to not take the recommendation, really helps when it doesn't go well, to say, this is where we're at and this is what we talked about.
Thank you. Thank you so much to the both of you. And Leslie, I saw your comment in the chat. I really appreciate that. And Dawn, I saw you turn off your microphone, but unfortunately we have to end because it's 3:59 and I know folks have other commitments. So I'm sorry that we didn't have a chance to hear from you, but I wanted to make sure as we close up that folks know what we're talking about next week. We will be here next week, Thursday at 3 o'clock with Skyland Trail. So we're going to be joined by their Chief Medical Officer, Dr. Ray Kotwicki, and talking about the mind-body connection and why integrative care is essential to mental health treatment. So continued conversation to some of the points we made today. I'm really looking forward to seeing you all there, and so much gratitude for those of you from Mountainside that joined us, Alex in particular. Thank you so much for your work, and hope to see you all next week.
Thank you all very much.
Thanks, Alex. Thanks, Lloyd.